I'm Allison Kurian, and I'm pleased to speak with you today about the clinical management of moderate penetrance genes. These are my disclosures. So what is moderate penetrance? This schema from a 2008 publication by Folks in the New England Journal of Medicine gives a good concept of it. And here we see on the y-axis the relative risk from 1.0, the average woman's risk, up to 10-fold. And then on the x-axis, the minor allele frequency, or how common the mutation or pathogenic variant, as they're sometimes called, are in the population. Early on in our understanding of breast cancer genetics, most of the action was up here in the upper left-hand corner of very high-risk alleles, BRCA1, BRCA2. And in more recent years, we've begun to look with genome-wide association studies at more common low-risk alleles. The spot in the middle here, shown by the red outline, is rare moderate risk or moderate penetrance cancer-associated risk alleles. And in this category go genes like ATM, CHEK2, PALB2 in some studies, and others. Here we're generally talking about 2 to 5 times higher than the average risk and a lifetime breast cancer risk of higher than 20%, but lower than 50% in most studies. 2021 has been a great year for the genetic epidemiology of breast cancer. There were 2 very important studies published in January in the New England Journal of Medicine. One of them was by the Breast Cancer Association Consortium, including 60,000 breast cancer cases and 53,000 cancer-free controls. And in this figure, we see the prevalence in this study of pathogenic variants or mutations in cases and controls. And as you can see here, I have highlighted this group of relatively more frequent mutations. And in this category, you can see several of the moderate penetrance genes that I mentioned, ATM, CHEK2, PALB2. The other very important study published in the New England Journal in the same issue was the Carrier study, which looked at more than 32,000 breast cancer cases and a similar number of cancer-free controls who were not selected for family history of breast cancer or early disease onset, which is very important for generalizability to the broader population. And here we see associated risks of different subtypes of breast cancer, ER positive, ER negative, and triple negative, largely grouped together. And we see that for the most common subtype, ER positive, we can see odd ratios in line with moderate penetrance for ATM, 1.96, for CHEK2 at 2.6, and NF1 really seems to fall into this category around 1.6, rounding up to 2.0, PALB2 here as well at 3-fold. When we look at ER negative or triple negative breast cancer, what we see are slightly different odds ratios and associations. We know that BRCA1 and BRCA2 are strongly associated with triple negative breast cancer odds. We do see some that would qualify for this moderate penetrance category for triple negative or ER negative disease, including BARD1, RAD51C, and RAD51D. And when we look at the study of the Breast Cancer Association Consortium, again, looking at estimated absolute lifetime breast cancer risks, we see categories of high penetrance genes for BRCA1, BRCA2, and really PALB2 on the borderline between high and moderate penetrance. ATM and CHEK2 clearly in the moderate penetrance range, and again, moderate penetrance for ER negative disease with BARD1, RAD51C, and RAD51D. And all of this translates into current practice guidelines, including those of the National Comprehensive Cancer Network, which are shown here in terms of gene, the risk level, the absolute estimated lifetime risk, the recommended screening, and whether preventive mastectomy is recommended to be discussed. We see that for the very high penetrance, high risk genes, screening is recommended to begin very early, 20 to 30 with breast MRI, and discussion of preventive mastectomy is warranted because of the high risk. As we look at more moderate penetrance genes, ATM, CHEK2, and F1, we see later recommendations for adding MRI around 40, although that is still being worked out. And we see here insufficient evidence to discuss prophylactic mastectomy, largely because the risk isn't as high. And again, we begin to see some developing evidence for what we might consider these moderate penetrance, triple negative or ER negative genes. Now let's move into talking about management of risks with these mutations or pathogenic variants. And here, a lot of the data is going to come by analogy to BRCA1 and 2, which we've been studying for much longer. So there was a nice review of imaging with different modalities, breast magnetic resonance imaging, which really is the mainstay in high-risk women, mammogram, and ultrasound in terms of sensitivity, specificity, and positive predictive value, looking at prior studies and different populations, BRCA mutation carriers and those with strong family history, dense breast tissue, family history alone. And we know, of course, that MR imaging tends to have the highest sensitivity, somewhat lower specificity, a bit higher false positives, and positive predictive value generally in line with the others. One important study recently from Dr. Warner and colleagues in Canada looked at long-term follow-up of women with BRCA1 and 2 mutations who were followed with screening incorporating breast MRI and found quite reassuring long-term survival, freedom from breast cancer death in this setting of 90%, only 4 breast cancer deaths among 72 subjects with 20-year follow-up. So again, we have to extrapolate from BRCA1 and 2 to the moderate penetrance genes, but I think data like this are quite reassuring. How might we begin to make estimates specifically for genes like ATM, CHEK2, and PALB2? Well, one way to begin to extrapolate from the BRCA data is simulation modeling. And a major consortium working on this is the CISNet, or Cancer Intervention and Surveillance Network Consortium, where models are used that have a population component identifying a birth cohort through an incidence and natural history component, a screening component, a treatment and survival component, using the best inputs available and allowing several different modeling groups to converge on estimates. So Dr. Lowry and colleagues presented a CISNet-based modeling analysis of screening benefits with mammography and MRI at various starting ages at the ASCO meeting this year for ATM, CHEK2, and PALB2 pathogenic variant carriers, estimating a mortality reduction in range of 50 to 60% with starting MRI around age 30. And so this allows us to begin to extrapolate the data to begin to think about making evidence-based guidelines before we have long-term follow-up data, specifically in these populations, which will come. So what about risk-reducing mastectomy, which, as I've told you, is certainly indicated for discussion in those with high penetrance or high-risk gene mutations? Again, we have data for BRCA1 and 2 carriers, but not moderate penetrance carriers. But this interesting study from Heemskerk, Gerritsen et al. In the Netherlands in 2019 looked at long-term follow-up of carriers of BRCA1 and BRCA2 mutations who self-selected into surveillance with MRI versus risk-reducing mastectomy. And they did find that with BRCA1, there appeared to be a small difference in survival, 99% versus 93%, that did meet statistical significance here for BRCA1, but no such difference with BRCA2, 98% and 100%, no significance in the p-value. So certainly suggesting that comparable outcomes can be attained, particularly in those with the lower risk BRCA2, and suggesting that it seems unlikely that we will see a substantial difference in survival between mastectomy, if chosen, and MRI-based breast screening in women with lower risk, moderate penetrance mutations. So what about medical risk reduction with drugs such as tamoxifen, raloxifene, or aromatase inhibitors? These are guidelines from the US Preventive Services Task Force in 2019 and give a nice summary of the estimated benefits per 1,000 women over 5 years of use with the SERMs, tamoxifen, or raloxifene, and the aromatase inhibitors in postmenopausal women, along with various adverse effects such as thromboembolic events, endometrial cancer, or cataracts, and do give the recommendation of considering these medications for women at increased risk, not for those who are not. Well, certainly moderate penetrance carriers probably would fall into this category, even though not explicitly named in these guidelines. I think one interesting recent study that may have applicability to this population of moderate penetrance carriers, although it did not study them directly, was the Decency et al. Study of low-dose tamoxifen published in the Journal of Clinical Oncology 2 years ago, where in a randomized trial of women with hormone-sensitive or unknown atypical hyperplasia, LCIS or DCIS, relatively small study of 500 women, were randomized to tamoxifen at a low dose of 5 milligrams versus placebo for 3 years, with a follow-up time of 5 years. Excellent side effect profile with very little in the way of toxicity, and a promising looking hazard ratio here for any breast event of 0.48. Again, we should make the caution that this is a small study with short follow-up, but I think intriguing to many patients and doctors and suggestive that it may warrant study in pathogenic variant carriers with moderate penetrance genes. So what about treatment? There is some emerging evidence that these findings may be relevant to treatment decisions. Tung et al. Studied PARP inhibitors and looked at women with pathogenic variants in genes other than BRCA1 and 2. And we see here in this diagram that there is a signal for a good response, particularly in women with PALB2 pathogenic variants with metastatic breast cancer in this study. The WeCare study, which looks at contralateral breast cancer risk, looked at this in terms of women who'd received treatment radiation for one breast cancer, looking at risk of a contralateral breast cancer, and finding no evidence of a significant increase in risk for women with ATM or CHEK2 or BRCA1 and 2 pathogenic variants, leading to guidelines that tell us there is no convincing rationale to withhold clinically indicated radiation therapy with ATM, CHEK2, or BRCA1 and 2 mutations. There is also some new evidence for prognosis of breast cancer in pathogenic variant carriers. Our group looked at this in a population-based group of patients accrued from SEER registries with genetic testing results and found no evidence of increased short-term breast cancer mortality in any subtype, ER/PR positive, HER2 negative, HER2 positive or triple negative with any pathogenic variants in BRCA1 or 2 or other genes, including ATM, PALB2, and CHEK2, and did find significantly reduced mortality with the BRCA1 pathogenic variants and a trend toward the same with other genes as well, suggesting there might possibly be some differential effect in terms of chemotherapy, but of course, further study would be needed to confirm any of this. There was also a study recently published by Fashing et al. Looking at metastatic breast cancer patients and seeing no difference across different genes studied in terms of outcomes, which is reassuring, certainly, that patients seem to do no worse. An interesting emerging area here is looking at polygenic risk scores, multiple single nucleotide polymorphisms that are beginning to be used in research to stratify the breast cancer risk associated with pathogenic variants in these different moderate penetrance genes. 2 studies shown here by Gallagher et al. And Gao et al. In the last year that have a similar sort of result in both of these cases. And I think, again, a very interesting topic for research, though additional validation is needed. And I will comment that there has been some evidence of challenges in implementing this kind of information into clinical practice. We did a study in a population-based setting in the SEER registry, again, looking at treatment by genetic testing results among breast cancer patients who had negative variant of uncertain significance only or pathogenic variants in BRCA1 and 2 or other genes, including moderate penetrance genes, seeing more bilateral mastectomy, which makes sense in BRCA1 and 2, maybe not so much in the moderate penetrance genes, but more worrisomely, some lower use of clinically indicated radiation therapy and a trend toward higher use of chemotherapy in very low-risk women with low oncotype DX21 gene recurrence scores. There was a very interesting study by Dr. Susan Domchak and colleagues, the PROMPT study, that looked at women who underwent risk-reducing salpingo-oophorectomy with a number of different moderate penetrance gene results, variant of uncertain significance only, or pathogenic results in these genes, and found that really for a rather alarming number of patients, this surgery was recommended by a clinician or discussed when it really would only be indicated for discussion in women with a PALB2 pathogenic variant or likely pathogenic variant. So providing some evidence that perhaps clinicians may not fully understand what to do when these gene mutations are found. So in summary, I think there are a number of key future directions and research priorities here. It would be good to begin to validate personalized risk estimates with polygenic risk scores across diverse populations of pathogenic variant carriers in high and moderate penetrance genes. Clearly, we'd like to optimize screening and prevention recommendations by gene, as well as gathering gene-specific data on risk-reducing medications, as well as clinical trials of new targeted therapies. And finally, I think there remains a need for education and risk communication for clinicians and their patients. I'll stop here and thank you very much for your attention.